Hi, everyone. I'm Pollokseni Combs, Program and Management Analyst for the DoD Medical Ethics Center. Welcome to our final panel discussion. I will be your moderator. Today, again, we have our esteemed panel of our subject matter experts, which consists of Mr. Joseph Procaccino, our legal advisor for the DMEC, as well as assistant professor at Uniformed Services University of the Health Sciences. We have Professor James Giordano, bioethicist for DMEC, and professor at Georgetown University Medical Center. And Dr. Megan Applewhite, bioethicist for DMEC, the director of the Alden March Center Bioethics Institute at Albany Medical College, as well as an associate professor at Albany Medical College. So today we will be having a lively discussion of some real life scenarios. I will read the scenario and then open it up for questions to our panel. So let's get started. Our first scenario is this. At 02:30 hours on a Saturday morning, dependent wife Claire comes into the emergency department of an MTF dragging along her 15-year-old daughter, Jane, who is screaming and trying to pull away from her mother. When the staff questions them, Jane tells the ED that she believes her daughter snuck out of her room during the night to be with her boyfriend, and they engaged in sexual relations. She demanded that the staff check her daughter to see if she was still a virgin. Jane, in response, yells, "Don't touch me. You have no right to touch me. I refuse." The staff quickly check to see if there are any medical records for Jane and discover that she has been seen for standard checkups and illness care throughout her life at the MTF. And that last year she came into the MTF on her own to see a provider to ask for birth control, but did not want her parents to know. This is permitted by host state law for mature minors, who the state defines as anyone over 14 years of age. Jane claims that while she did go out to a party that night with her boyfriend, they did not engage in sex. The staff member tells the mother that because Jane is a mature minor, they must respect her wishes and will not do the examination. Claire then tells the staff that the boyfriend is a 20-year-old private first class on the post who had recently been accused but cleared of improperly touching a worker at the PX. Jane insists that her daughter is covering up a statutory rape, but before calling the MPs, she wants to have evidence. What does the staff do? Mr. Procaccino, go ahead and start, please.
Let's go ahead and, as the sports analysts say, let's roll the tape. When we start looking at this particular issue, it would seem to me that a number of factors may come into your mind. One of the most important ones, of course, being the issue of informed consent. The question here, though, is informed consent from whom? Normally, when you're dealing with a minor, someone under the chronological age recognized by the law of the jurisdiction, it is the legal guardian, and in that case, in most instances, the parent or parents that would speak for the child. However, as most of you are probably very, very well aware, that virtually all jurisdictions have set aside special laws for what is deemed to be a mature minor. And this is a wide-ranging definition depending on the jurisdiction that you're in. Some states have no age specificity for maturity. Other states will set limits such as 14, even 12, 16. But the state would say that when you've reached that age, you may be deemed mature enough to receive certain types of medical care, either without the consent or knowledge of the legal guardian or parent in this case. These usually are seen for care, say, for sexually transmitted disease, for alcohol-related issues, drug-related issues. But one of the more controversial ones that come into play would be the issue involving reproductive matters, such as birth control, and in some jurisdictions, even the issue of abortion. Here, we're talking about someone that is being asked to be checked for something that is very, very private to her, that is, at least on its face, a social, or may be considered a social as opposed to a medical issue. And that may be why the staff is somewhat reluctant to initially want to honor the request of the mom here. But the mom throws a curveball, and she says that the boyfriend is 20 years of age. And again, in most jurisdictions, there is a delineation sometimes for sexual activity that if the difference in age between one and the other party is more than 3, 4, 5 years, depending on the jurisdiction, it may be deemed to be statutory rape, even though both parties had consented to the sexual relations. If it is indeed a crime here that's being committed, does that change the rules of the game? And here then, does the medical staff intervene on behalf of the mother, overriding the daughter under these circumstances? So you've got the social versus medical concern. You've got the potential for criminal activity, of course. You also wonder about the motivation of the parties. What is the reason why the mom is pressing this so hard? Is it because she simply doesn't like the boyfriend and she's trying to drum this particular case up to get him into further trouble? Is the daughter further denying when in reality she did have sex with the individual? And there's so many stories to this soap opera, but it goes back again to informed consent and the dilemma that the providers are going to have to face as to really, do you intervene, how you intervene? But it also brings into account, again, communication. Do you want to bring the judge advocate's office into this? Do you want to bring other people from the hospital to speak to the daughter, to speak to the mother, to try to get more objectivity in the way this is going to be handled? I then yield to my other colleagues for further comment.
I would say that, to me at least, the answer to this is relatively straightforward, and that is that the game doesn't change. The answer doesn't change, regardless of whether or not the mother is concerned about the daughter covering up statutory rape. There is no world where it's appropriate to violate the body of this mature minor in order to gather evidence if she says no. I would also argue that this further could traumatize her in ways that are far worse than her relationship with her boyfriend, by suggesting when she says no to an exam of such a nature, that in fact, those individuals that are employed by the military training facility and her mother have the ability to say yes and override her. So to me, although I think that, an argument can be made for the other side, it's not one that would be the right thing to do.
Yeah, I concur with both of my colleagues. There are a couple of ethical issues, I think, that ground not only the situation, but the trajectory towards its resolution. The first is with a mature minor, you have the idea of transitional consent. In other words, formal assent becomes consent in a medical legal context if, in fact, that minor is deemed to be a mature minor. Point number one. Point number two, which really reflects back upon the legal issue, is whether the age delta, the difference between the individual who is the enlisted personnel and the individual involved with regard to consensual sexual relations is greater than what would be then prescribed by that particular jurisdiction as being viable for the relations between an individual who may be considered an adult and a mature minor. Again, those are more legal precedents than they are ethical. But the bottom line is the ethical issue of assent to transitional consent and violations of the individual, in this case, the daughter's autonomy, which is what Dr. Applewhite alluded to. So the issue here, of course, is whether or not the medical staff wants to exercise frank paternalism or wants to engage in a more prudent process of parentalism, whereby ethical judgment is made prudently based upon evaluation of all the situations present, the facts, and the relative relationships and roles of the parties involved. Simple execution of a medical decision to move in a direction whereby the physician exercises control is realistically a dated form of paternalism. However, acting in the patient's best interest and in those interests that see, if you will, over the crest of the crisis, represents medical parentalism in the best interest of the patient. And in this case, as mentioned before, the patient's best interests are threefold. Number one, whether or not a crime has been committed and charges wish to be filed, particularly by that patient, which is absent in this situation, given the consensual nature of their relations. Number two, that the patient explicitly states that any contact with regard to physical examination would represent a perceived violation of her exerted autonomy, and she's exercising said autonomy within the ethical legal construct of the negative right of refusal. And third, as a mature minor, transitional consent from assent would suggest that this individual did not provide a or transitional consent and therefore represents an ethical legal violation which could be deemed as potential assault, which then feeds back onto the probity of the clinician-patient relationship in that the nature of that, the intimate nature of that, is based upon patient's best interest and the fourfold good: the biomedical good, the good for the patient's choices, the good for that person as a patient, and the larger existential good that extends beyond that patient, perhaps to medicine as a public good. So the contingencies here would certainly weigh against advancing the examination. And in these ways, I side with the opinions and perspectives of my colleagues.
Now, if I could just come back on this a second, because what the commentary does provoke is something that was kind of sneakily included into this scenario. And that, if you remember, is the issue involving the fact that they had seen the medical records of the daughter, and they did know that she was getting birth control. Now, what does this mean to the hospital staff? That she's already having sexual relations? Has she admitted that as a reason for getting the birth control when she went to the facility? And if that's the case, obviously there's a disconnect, because it's fairly clear that the mom still believes she's a virgin. Now, she hasn't told her mom about her sexual activity other than this gentleman, presuming she did have sex with him. So you have that as an additional factor here. And whether or not the hospital feels that they might be able to ameliorate the problem by suggesting that, well, it's not going to make any difference whether we check to see if she's a virgin or not here, because it's not going to answer your question unless we actually go further and do a rape kit. And then we get into the criminal aspect again, as Dr. Giordano just brought up. So again, there may be reasons why, if the mother is that adamant that the statutory rape has been committed, that the proper venue may actually be the military police or law enforcement. But you do not necessarily want to put the medical staff in this situation of being the police, because that is really not their purview here.
Great. That's very interesting. Thank you for your perspectives. Let's move on to scenario B. Tom and Linda both grew up as orphans with no known family, living their entire lives in orphanages and foster homes. In high school, while living in separate foster homes, they met in a class and soon fell in love. Both were 18 when they graduated and were married soon thereafter. Tom immediately joined the Air Force. 4 years later, Linda began having significant chest pain and fainting spells and went to the MTF. The providers admitted her for a battery of tests. At the completion of the tests, her doctor came to see her with news that the tests revealed that she had metastatic breast cancer, which had metastasized to her spinal cord and into her brain. When pressed for a prognosis, she was told that she likely had about 2 to 3 months to live. She asked if anything could be done. The doctor said an aggressive chemotherapy regimen would not cure her, but might extend an additional 3 to 4 months. But the quality of her life would be horrendous. The doctor then revealed to Linda that she was also about 2 weeks pregnant. Linda, more than anything else in her life, wanted to have a baby. And when she heard this news, she calculated the pregnancy time and suggested to the doctor that with the chemotherapy, perhaps she could live long enough for her baby to be delivered as a legacy of her in this life. The doctor responded that if she got the chemo, there was no guarantee that she would live that long, and even if she did live long enough, no guarantee of a live birth. And if the baby were born alive, the odds of having a severely physical or mentally disabled child were almost a certainty. Linda replied that the baby's condition was not important to her. The fact that it would come into this world as a new life and a progeny of hers was paramount. She told the doctor to do anything possible to keep her alive, even as a human incubator, should she become unconscious, just to get the baby to a live birth. This MTF did have equipment available to do this. A social worker met with Linda to again explain the circumstances, but Linda had made her intentions clear, and the social worker felt that Linda was competent. Linda said that she had completed a durable power of attorney for health care, giving authority over her care to her husband, Tom, should she no longer become capable of doing so herself. Later, the social worker met separately with Tom. Tom told the social worker, after ensuring that their conversation was private, that he thought his wife was being unreasonable and selfish, and that even if this baby was born alive, Linda would be dead, leaving behind a highly likely damaged infant, with he alone in the world to have to raise it. Shouldn't I have a say in this matter? He said. He told the social worker that he does not want to upset his wife. If and when his wife is no longer competent, he, having power of attorney, will order the respirators removed, or in the alternative, the fetus aborted, because he believes this would be more merciful for his wife and child. Mr. Procaccino?
There are several issues here that one has to kind of work oneself through. And it's a horrible, horrible situation for a young family to have to face. But when you're looking at this, just as we had for the previous scenario, the central theme, I think, is again going to come down to informed consent. But here, we're dealing with a number of different vested interests. I would suggest that obviously we're dealing with the wife in this situation who has the cancer, received a very devastating diagnosis and prognosis. But when she started to put the numbers together after seeing that should she get chemotherapy, there was at least a chance that she might be able to deliver the baby that she was carrying, that seemed to be her central motivation, to try to stay alive long enough to have this child, even though she had been told that the route of getting to that point could be horrendous for her because of the doses of chemotherapy that are being given, not to mention the likely outcome of problems to the baby because of the chemotherapy at the same time. So it raises the question of consent for the mom here to continue the treatment that is being given. But one also has to look at the issue of the husband here. And he raises an interesting point, saying that if the wife is allowed to do what she wants to do, and then she ends up dying, and she leaves behind a living child, and this living child does have significant problems or special needs, he's alone in the world to raise it. She's kind of dropped this on him. Doesn't he have some say in this matter, according to the scenario that Ms. Combs just mentioned? And should some deference be given to his decision-making, particularly since he was appointed as the essentially attorney under a durable power of attorney for health care? Now, you throw in a couple of other curveballs into this case. The social worker is meeting with both of them, and she's apparently passing medical information back and forth, which brings up an interesting legal issue of whether or not there's been a HIPAA violation here, or could potentially be a HIPAA violation because of passing personal health information, and particularly since the husband had mentioned he presumed that the conversation he was having with the social worker was private. So did the social worker make sure that permission had been given for both parties to share information with each other? And it's a question quite often that is presumed by providers when it hasn't really been ascertained. You also have another party here, though, the fetus/baby in this case. Are there certain rights that are vested there that should be considered? It's interesting from a legal and even ethical point of view that there's a great deal of emotion attached to those two words, fetus or baby. And a lot of it simply depends on the ethical, religious, cultural background that someone has as to how you term the entity sitting inside the mom's womb there, or the woman's womb. I even say woman as opposed to mom, because this becomes a very critical piece of evidence quite often that is in front of a jury in a courtroom. Imagine, if you will, a malpractice case involving the death of a fetus. And one attorney gets up and asks an expert on the stand, "Doctor, what would you estimate the gestational age of the fetus at the time of its demise?" Now, hearing that question, I presume in the back of your mind, you understand that question. But the same question asked by the opposing counsel, "Doctor, how old was that baby inside the womb before it was killed?" Now, the jury, lay people, are going to pick up on certain emotional words here, which don't sound as scientific or medical as the first question, but evoke emotion. And those are the kinds of things that if a case goes into court, judges and juries are going to be listening to and looking for. Now, in this case, the mom is wanting to have this child. So there's not an issue on her mind about abortion per se, but that's relegated to the father in this particular case, where he thinks an abortion is actually in the best interests of both his child and his wife. Does he have the right to say that? That's the problem that we're facing here, among others. I yield to my colleagues.
It is really, it's a really challenging case. And as Mr. Procaccino points out so aptly, that there are so many different perspectives and sort of qualities of life to consider. Does this woman who has capacity have the right to maintain a pregnancy that at the time of conception was arguably wanted or, not actively prevented? Sure. Yeah. So does the husband, the father of the child, have the right to weigh in on a decision of whether or not to carry this pregnancy to term, given the high likelihood that it isn't going to be a totally healthy baby and that he will certainly be raising it without the mother? And, sort of looking at these different perspectives, what comes up is what Mr. Procaccino pointed out in the last case, which I think is pervasive in so many ethically challenging cases, is communication is so important. The fact that this father is having the discussion with the social worker and not really with his wife to say, I think this is kind of selfish, and I love you and I want for you to be happy and I want to fulfill your goals and objectives of care. And in your last few months of life, I want for you to feel you're leaving a legacy. But imagine on the other end what it's like. I'm losing not only my wife, but I'm gaining a child that I will not have any help in raising, and So, I think the idea of the communication maybe be encouraged, it would be really helpful. Professor Giordano, I'm not sure your thoughts. I would be interested to hear.
Dr. Appel raised a number of good points. I mean, much of this revolves around, once again, the legal basis of this, but there are some ethical precepts that I think are important as guideposts. Considering that a 5-step process in resolving any form of equipoise, inclusive of ethical equipoise, what are the facts of the case? 2, who are the individuals involved? What are their roles? Number 3, is there an ethical issue and what is it? Number 4, what can be done? And from those trajectories and their outcomes, determining what should be done. And the best interest standard is multifold. Clearly, one of the issues becomes, well, should we terminate the pregnancy? Or should we engage what might be relatively heroic efforts to extend the mother's life to sustain the pregnancy, given the fact that this is perhaps a high burden and or high risk pregnancy for the developing fetus, ultimately the subsequent baby, the neonate? And then what will that incur for the quality of life of the neonate, number 1? Number 2, what will it incur in terms of the biopsychosocial stressors upon the surviving relative, in this case, husband and father? And number 3, there is a historical issue here in that both mother and father were orphans. And there is indeed perhaps an emotional likelihood that would suggest there may either be some disposition or antidisposition towards putting the child up for adoption, which would then impose an additional psychological, social, economic, if not emotional burden upon the father to remain as durable as conceivably possible in the role of a father, given the fact that being an orphan and being raised was in their personal history. So scenarios and putting these together, I think it becomes very, very important, as my colleagues have stated, to facilitate multifold communication. Communication with regard to the medical realities of this case, vis-a-vis the likely outcomes to the developing fetus cum neonate. Number two, the outcome they will then yield in terms of the burden of care upon the father. And number three, the basis of the mother's decision-making process and what the emotionality incurs based upon not only the individual's capacity, clearly she's capacitous and therefore competent, but how emotionality weighed into her disposition towards the facts of her case and particular burdens and directions that would then need to be placed upon the medical staff to sustain quality of care, both upon the mother and the child. So I think the issue here is one of multifold ethical, legal, and medical communication to be able to determine what can be done, and from what can be done, project the trajectories of what those outcomes would most likely yield. And from communication of what can be done and the viable likely outcomes, what should be done in the multiple interests of those parties and agents who are involved.
Very interesting. Lots to think about. That's a tough one. So let's move on to our third scenario. Corporal Davis is grievously wounded after stepping on an IED in the AOR. Brought to the surgical tent, the providers see that both his legs have been blown off, as well as his left hand, and shrapnel has punctured his left eye socket. He has an open wound in his abdomen, which is bleeding. The surgical team confer and conclude that they can stem the bleeding, stabilize the remainder of his limbs, and get him flown to Germany. Davis is conscious and cogent, and he hears this condition. He looks up and begs the providers not to stabilize him, but instead give him pain medication and let him die, as he does not want to live the rest of his life like this. The providers consult with medical command, who direct them to proceed with the surgery to stabilize and evacuate him, telling them that if they accede to his wishes, what would be the message we are sending to our troops about doing our best to save them when they are injured? Besides, it's likely that if he makes it through this, he will thank the providers for not listening to him during this traumatic time. What should the providers do? Mr. Procaccino?
It would seem to me that we've seen in the other two scenarios that have already been mentioned, how important the informed consent issue comes into play once again here. But this is a very good example of the dilemma quite often that is felt between the autonomy of a patient on one hand and the beneficence of the provider on the other, and how the two may actually clash. Now, there are other factors that are brought into this particular scenario, including what I might suggest would be the dilemma that active duty members will face of really dual loyalty. Because in many instances, one's professional ethic might indeed be to respect the autonomy of the cogent patient here, to allow them to die because of the grievousness of the wounds here, as opposed to the issue of the mission here, if you will, where the military, the command is suggesting that there is a higher need or good for trying to save this individual that goes beyond the individual himself, i.e., that you don't want to send a bad message to other people in the field about our lack of wanting to do everything possible to be able to get someone to recover. Plus the fact that over the years, particularly since this kind of scenario happened in the past 20 years, that we've seen incredible developments as far as the use of prosthetics and rehabilitation at some of our excellent facilities. And whether or not this young man is aware of the potential that could be done may not be available to him at that particular moment. So all of these things are kind of balanced. Plus you have the additional mission issue of the fact that this person has some intelligence type of abilities in the sense of language ability and knowing local population, which may be of benefit again to the mission. And should that override the autonomy? And so you've got this mission versus personal conflict, just like the autonomy versus beneficence conflict. This also, to me, brings into account the issue of making a presumption as far as what somebody really wants. And this goes back to a principle, and perhaps Dr. Giordano or Dr. Applewhite may be able to comment more as our pure bioethicists here, something called the Ulysses consent. And under these circumstances, we see that there are people that may, at first glance, consent to a procedure. But once the procedure begins or treatment begins, they suddenly react just the other way and say, don't do this, stop this. The question then becomes, when they say stop it or don't do it, did they suddenly become incompetent or lose their capacity? Or were they incapable of having that capacity previously because of the nature of the injury or wounds, and now have capacity to change their mind? Or can they simply change their mind? And again, this is a dilemma for providers to kind of figure out. Are they or aren't they? And if they change their mind, do you honor the change of mind? And this becomes a problem. We've seen this with Jehovah's Witness cases where, due to unusual circumstances, providers have overridden patients' refusals to be transfused, particularly, say, with children, even to the point of getting a court order. But instead of going into litigation, that patient or the patient's family bring flowers or candy to the provider saying, thank you for making the decision for us. Or in other cases, it was the pain talking, thanks for not listening to me. But that's one side of the story. The other side of the story is the person who does have capacity, but says, why did you do this to me? Look what you've left me like. And I've heard about all these wonderful things at the rehabilitation centers, but I have no family. My girlfriend just left me. I'm going back to the middle of the U.S. to a small rural town where the nearest veterans hospital is about 60 miles away. I've got very little support mechanism at home, and this is what I'm being left at with a high school education. Thank you. Please let me go. That's the nature of the dilemma here. I yield.
I think that's an excellent summary of a very difficult case. And I think one of the things that is sort of yet a third perspective is the perspective of the surgeon taking care of the patient. And that is to say, it's a challenge whenever you see a problem that you think can be fixed, that isn't an imminently life-ending issue in front of you, and just allowing the person to die. So, as is discussed with hunger strikes, should someone be allowed to strike because they, have a deeply held belief that is consistent with them not eating unless, X, Y, or Z happens. And it's one thing to say, yes, that person should have the autonomous choice to decide not to eat. On the other hand, if you're the physician who's rounding on that patient every single day and you see them physically actively dying and you're not doing anything about it, it doesn't feel good. It feels terrible, right? So if this person has significant injuries and has a wound in his abdomen that you can stop the bleeding on, and he's not actively dying anymore, is that something that you're okay with just not helping? The point about sort of whether or not the patient has capacity is another really good one. So is he in shock? How much blood has he lost? Does he truly have capacity in the state that he's in? And so is he actually making an informed decision? And how can you possibly know that? How can you possibly know if he's going to be the guy that comes back and acts in intelligence and is really a true asset later on, or if he's going to be the guy that goes back, to his town in middle America and is alone and feels profoundly depressed? You can't possibly know that. What you can know is whether or not this patient right in front of you is someone that you can help at the moment. And so it becomes really difficult to be in the middle of that scenario where you say, yes, this person can continue to live if I do X, Y, and Z, but they're telling me they don't want that. So there's sort of the added dimension of the surgeon taking care of the patient who can help and is being told not to help by the patient themselves.
Good points, all. So a number of factors I think are brought to the fore. My colleague, Professor Procaccino, mentioned the Ulysses clause, or Ulysses consent. In other words, strap me to the mast, and then when we're subject to the siren's call, this is what I need you to do in advance. So when things get blown to the wind, literally, this is what I need you to do. However, very often what can happen is, even though the sirens may be calling and the temptation is to go in a particular direction, New tools and new methods may be available. And this gets back to the nature of informed consent. How much do we know? And how much can we then take this particular patient over the cusp of their crisis to be able to see into a probabilistic and predictive future of what medicine and medical biotechnology can afford with regard to their viable rehabilitation, not only in terms of quantitative recovery, but quality of life and the capability for activities of daily living within the occupational scenario that this person then can resume, which then gets back to force preservation and force economy. So the issue here may be, as we've heard earlier, one of communication that is an important component and a contingency for informed consent. These are the things that we can do for you. These are the things that we will be able to achieve with regard to medical recovery and rehabilitation. And these are some examples of others who may have been in a similar situation, who may provide narrative, exemplar, or in some cases, counseling to be able to provide the necessary information so as to more viably inform your consent or non-consent. Point number one. Point number two is the point that Dr. Applewhite brought up, is that in the patient in the time of crisis, very often, although may have capacity, may be compromised with regard to their cognitive and emotional clarity, being able to see what consequences may yield, particularly given the emotional nature of what has been incurred to them and what may then be viewed as their life choices. So in this particular instance, it becomes important to then reconsider the fourfold good that goes into any ethical and or clinical decision-making. Number one, the biomedical good. In this case, it really is a question of what can be done. And what can be done may allow this patient a return to an active quality of life that quantitatively can include a whole host of things that can then be maximized and optimized through the available technologies, both in the proximate and the intermediate sense. Number two, good for the patient's choices and good for the patient as a person. Here it becomes important to appreciate those patients' values and then try to aim and inform that patient that the availability of techniques and tools can restore some of their personhood vis-a-vis their values, their goals, and their choices. This then embraces what Fulford has referred to as values-based medicine and what Waters and Serpina have called goal-directed healthcare, all of which are necessary contingencies for consent because they provide less than proximal, less than immediate information that may be important to determine the patient's reassumption of what may be their construct of, in the phenomenological literature, what is called their life world and what their lived body may obtain and entail. Ms. Combs, back over to you.
Great. Well, thank you all for that. So this brings us now to our final scenario. This one is a little convoluted, so I'll read it slowly and see, hopefully you can follow along, and then we'll discuss it. Captain Rocco Smith, an unmarried fighter pilot, is in a practice flight when his fighter loses power and his ejection seat fails to open. Rocco makes a crash landing. A rescue team is able to extract his body from the wreckage and transport him to the MTF on base. There, though a ventilator kept his lungs and heart functioning, an electroencephalogram indicated brain death, and he was declared dead. His sister, Captain Sabina Smith, an active duty nurse who happens to be stationed at the same base as Rocco and working at the MTF, is notified of the crash and is at the hospital when the pronouncement of death is made. She asks that Rocco's sperm be harvested so his family might be able to later arrange for it to be used to have his offspring via artificial insemination. The MTF has harvest and storage capability and accommodates the sister's wishes. Sabina finds another nurse in her unit, Lieutenant Dorietta Doe, who agrees to donate ova to artificially create a fertilized egg with Rocco's sperm prior to her being deployed. Rocco's elderly parents support this decision after hearing of the harvesting because continuing the family name is a cultural requirement, if at all possible, and the artificial insemination is later done at the MTF. Sabina comes to the MTF a few weeks later with documents indicating that she is the executrix of Rocco's estate. She asks that the inseminated ovum be implanted into her so she can carry the baby and keep it in the family. This way, she could both be the baby's aunt and mother, thus obviating any need for future surrogacy and adoption issues. Many FTM personnel resist this request, citing religious objections to participating in this procedure and raising questions from some about abetting a quasi-incestuous birth, as well as concern from others about Sabina using the pregnancy to avoid an imminent deployment. Sabina is angry hearing about this from many of this staff to accommodate her wishes, and tells the nursing colleagues that in the MTF that if they will not do the procedure in the MTF, she will take the inseminated ovum per her right as the executrix of the estate and have it done at a civilian facility. She explains, I have a right to procreate and the military can't prevent that. Besides, if this were an organ donation, no one would complain or prevent that. I'm not asking for money. I'm just donating my uterus to help give life to another family member. What issues should the MTF staff consider? Mr. Procaccino?
What a way to end the discussion today. Incredible number of issues here, but again, as we've seen with the other three, the focus, it would seem to me, goes back to informed consent. The unusual part about informed consent here, though, is that we're entering into this kind of almost science fiction world of trying to obtain informed consent from a deceased individual. And if one has not mentioned that or made that clear prior to death, we're being very, very presumptuous here as to what the intent was of the deceased, as to what they wanted done with their body or parts of their body. Now, what complicates this is that when we've seen this occur in certain circumstances, generally it's been the spouse that's made the request. And when these cases have come up in the civilian world, and they've even had to go to court, the courts seem to distinguish between a presumption of consent on the part of a spouse to be able to speak for a husband who may not have made his wishes known in this situation, if those states allow that at all, because otherwise some states will say, unless we see something in writing from the deceased, then we're not going to permit this. And then again, we also have a problem with the issue of the sister and whether or not she is the appropriate person to kind of take control over this. Being the executrix of the estate, does that give her kind of plenipotentiary right to be able to become the donee? We have another issue here. She quote unquote asked Lieutenant Doe, and Lieutenant Doe was going to donate her egg. The nature of that ask, we're talking about two active duty individuals here in the military treatment facility. Was it purely voluntary, or was Lieutenant Doe, quote unquote, volunteered to offer the ova? Again, it's a factor that may come into play and has become an awkward issue here when we see active duty folks that one wonders, if they're going to participate, say, in clinical trials. Are they truly volunteering, or are they being volunteered? And it goes back to an informed consent issue once again, this time on the part of Lieutenant Doe, although there's not a lot of factual pattern here to work around that poor problem. We further have an issue involving definition of death. The individual shows a flat electroencephalogram, but a respirator is keeping the heart and lungs going. You need to look at the definitions of death of the particular jurisdiction to see whether or not that individual actually is dead, and whether or not that has any bearing then on a third party being allowed to make an extraction of the sperm, or another case of ova in these kinds of situations. So that becomes a factor too. And then you've got this awkward issue here of the quasi-incestuous relationship that may be involved here. Now, there is no genetic issue per se that one might argue here, because Lieutenant Doe is donating the egg, and it's the pilot's sperm, and his sister is simply being the carrier. But the fact remains that when the baby is born, the baby will, at least technically, if not legally, be the son-daughter of the sister, as well as the niece-nephew of that particular person. That creates significant social issues that I'm not really sure that the courts have fully grasped or able to grasp at this point, that becomes a problem too. So all of these factors, plus the other technological issues such as availability of facilities to do this. And again, what is the status of the embryo or the sperm or the ova that are involved individually here? And are they entitled to certain rights, as we've seen argued in courts in different parts of the country and around the world? It raises a tremendous number of issues. And when we're trying to be beneficent to people that are killed in the AOR but would want to have had children later on, how far can we go, or do we go, in order to accommodate this? And what are the limits of who may be able to obtain these particular products to be able to have that child later on? Finally, what would be the status of that child if the child were born? Is the child considered a dependent of the deceased? And if not, then are we letting that person lose benefits that if they were, in other words, born in a quote unquote normal situation, they would have had? That includes things as specious really as having PX privileges or BX privileges, but it could be something more significant, that other benefits that inure to dependents of military members. Is that a factor that should be considered as well here? So you see just a tremendous amount of not only ethical, social, administrative, legal factors involved. Pass on to my colleagues.
Let me jump in here next, because the case brings up a number of, I think, are catalyzed by us being on, if you will, the edge, riding the crest of what is capable of being done technologically, and then what that infers with regard to how ethics needs to adapt to scientific and biomedical technological capability, and vice versa. How scientific and technological and biomedical capability need to then be guided by ethics, ergo governed by law. A number of these issues are also potential straw man issues given these recent developments. So, as you may know, there are a number of instances in the literature where a family member has either volunteered for, or in some cases via discussion has then been identified as the most viable recipient for carrying an ovum to term, being able to be cross-fertilized, etc., and being able to then bear a child when other family members cannot. So the idea that there may be some religious prohibitions or prescriptions also speak to the religious orientation of the individuals involved, rather than just a generalizable religious prescription, or otherwise. But there is precedent for this. And in fact, I personally have encountered a number of cases where a family member has said, yes, I will then be the bearer of this implanted ovum, given that my other family members cannot bring the child to term. And in these situations, very often, as we mentioned before, consideration for informed consent, communication, and then resources are clearly an issue. This then speaks to the other issue of whether or not this child born would be considered dependent. And this speaks directly to the ethics of biological lineage. And the short answer to that question is yes, absolutely. By virtue of biological lineage, this represents the husband's or the lieutenant's sperm that has then been used to inseminate a donor egg, which in this case is being carried by the donor sperm's sister, which would then really give you a, quote, double dose, if you will, of viable military dependency. This then speaks to the third issue of what is sometimes referred to colloquially as Chinatown syndrome, from the movie of the same name. My husband, my brother, my husband, my brother. The issue there is this person who is then going to bring this child to term the aunt or the mother? Here too, this is, quote, splitting hairs. Biologically, this individual is their aunt. Socially, and by virtue of practicality, this then becomes their mother in that they gave birth to the child. In other words, they biologically birthed the child. And then the question is whether or not the sister, who would be the aunt, would then assume a maternal role by law, in which case, as an adopted parent, they are formally the mother. Here too, there are instances in the literature and legal precedents in a variety of jurisdictions that would suggest that not only is this possible, but this is very probable, in many cases has also been done legally. A more subtle issue here is the relative coercion of egg donor. And in these situations, one needs to be very, very cautious as to, within the chain of command, whether such coercion is a viable factor, implicitly or explicitly, whether this was something that had been discussed prior, whether this is consistent with the pre-existing relationship between the sister and the lieutenant who is donating the egg, and or whether there might have been other opportunities to more viably and perhaps voluntarily obtain a valuable ovum that could then serve as a vector for insemination. So again, here, I think it's a question of what are the options available and whether those options were fully exercised, and what are the nuances and particularities of the situation, and to determine whether or not there is an ethical issue present or not, or whether the ethical issue is basically predicated upon failure of, or at least some paucity of communication. The final issue, I think, is one that is going to be seen more frequently, and that is prospective organ donation and what that actually means for a variety of tissues. Does that uniformly include germ cells, sperm, ova? And or does organ donation also include whole body parts, limbs, and increasingly organ systems? And is this then a generalizable facet to any organ donation, whereby if an individual says, I want to be an organ donor, there needs to either be specificity in saying, I want to donate these particular organs, or take what you will, and somewhat quasi-science fictionally inclusive of the entirety of my body. And here I'm alluding to the looming reality of what may be almost, I think, science fictional in its scope, but certainly a biomedical approaching reality of body to head transplants. And here I allude to the work of the Italian neurosurgeon Sergio Canavero. An ethical issue has been raised with regard to, well, are we wasting organs if we simply transplant an entire body? And although at this point that's speculative and still relatively fictional, it does raise the point as to the need for specificity in what organs can be transplanted and how they might be repurposed and used, and what level of autonomy to dictate the prospective use of my tissues in future biomedical scenarios I can then assume and can exercise, which then feeds us back into the medical legal domain. Dr. Applewhite, over to you, ma'am.
I'm not sure that I could say it better than my two colleagues. I'll add a couple of additional points, but really I think it was very well covered. I think one of the questions that this can come down to in the end is, just because we can, does it mean we should? And to keep in mind that the physicians on the other end of this can say no if they think that one of their deeply held beliefs will be violated by implanting the embryo in the sister. Send her out. Let her go to one of the civilian facilities. The physician being asked to do this does not have to say yes. In the complexity of the scenario, it strikes me, is really accelerated by having the egg donor in play, right? Because then it transitions from having posthumously retrieved sperm that are being preserved to having an embryo. And that just holds different social quality, and it holds sort of more gravity to it, the fact that exists and not just the sperm itself. And so that's something that, as we've talked through, really does increase the complexity of the scenario and sort of makes more ready the idea of implantation. Whether it should be in the sister, again, is a very tangled event. As already very outlined by my colleagues. So I'll hand it back to you, Ms. Combs.
Okay, well, great. So this concludes our session for today. We hope you found it informative and interesting. And thank you all for attending. And we'll see you next time. Thanks.